those who are pushing these vaccine mandates and vaccine passports, vaccine fanatics, I would call them, to me, they have done much more damage during this 1 year than the anti-vaxxers has done in 2 decades.
When it comes to COVID immunity, vaccines, and the Delta variant, what does the existing research actually tell us? Today I sit down with one of the world's leading epidemiologists, Dr. Martin Kulldorff. He's a professor of medicine at Harvard Medical School. He helped develop the CDC's current system for monitoring potential vaccine risks. And he's also one of the co-authors of the Great Barrington Declaration, which argues for focused protection for the most vulnerable instead of lockdowns.
There's no public health reasons for it, so that's politics.
This is American Thought Leaders, and I'm Jan Jekielek. Dr. Martin Kulldorff, such a pleasure to have you on American Thought Leaders.
It's a delight. Thank you for having me.
So we're about a year and a half into the coronavirus pandemic. And, we've had lockdowns, we've had kind of emergence out of lockdowns. Right now in places like where I live in New York, we were getting closer to some kind of semblance of normality. And now we have the Delta variant, and there's discussion of lockdowns again. And we have countries that actually have been in perpetual lockdowns. And so you've described the global COVID response, I'll quote you here, as the biggest public health fiasco in history. Feels like a big statement to make. Tell me more.
Well, I think it is, and without doubt, there are 2 sort of aspects of that. One is, while anybody can get infected by COVID, there's more than 1,000-fold difference in the risk for death and the mortality risk between the oldest and the youngest. So with the naive belief that these lockdowns will protect everybody, which obviously we know now didn't work. A lot of people got COVID, a lot of people died. But there was this naive belief that they will protect the older people. And because of that, we did not implement basic public health measures to actually do what was necessary to protect those older, high-risk people. And because of that, many of them died unnecessarily from COVID. The other aspect of it is the collateral damage from these lockdowns. So, for example, children who didn't go to schools. The children are at minuscule risk from this disease in terms of mortality. They can get infected for sure, but the risk from COVID for children is less than the risk from the annual influenza, which is already very low for children. So for them, this is not a risky thing. And one example is Sweden. From the first wave in the spring of 2020, Sweden was the only Western country that did not close down all the schools. So schools and daycare were open for children ages 1 to 15. And among the 1.8 million children in Sweden during this first wave, there were exactly 0 deaths from COVID. And that was without using masks, without social distancing, and without any testing. If a child was sick, they were told to stay home, that was it. So this is not a serious disease for children, which we should be very grateful for. Also, young adults have very low risk for mortality from COVID. But the collateral damage has been enormous from these lockdowns. Cardiovascular disease outcomes, heart disease and so on, has been bad during this pandemic because people don't go to the hospitals, or there's not available the healthcare that they need. Diabetes patients, for example. Cancer have actually gone down in 2020 and 21, but that's not because there's less cancer, it's just that we're not detecting them. And if we're not detecting them, we're not treating them either. And this is nothing that shows up in the statistics this year, except to a very small extent. But let's say a woman who didn't get the cervical cancer screening might now die 3 or 4 years from now instead of living another 15, 20 years. So this collateral damage on public health from these lockdowns is something that we're going to have to live with and die with for many, many years to come, unfortunately. And then, of course, there's the mental health aspects, which has been enormous, tragic. So this has really been an awful response to the pandemic, and that goes against the basic principles of public health that we have followed for many decades. It's very unfortunate, I think.
Well, okay, so that's very interesting. You would think that the basic principles of public health would be implemented, I guess, in force in this sort of a situation. So how has that not been done?
That is a very good question. To be honest, I don't know the answer to it, because to me it's stunning as a public health scientist that we suddenly threw out these principles that we have sort of used for decades to deal with public health issues. One is public health is about all health outcomes. It's not just about one disease like COVID. You can't just focus on COVID and then ignore everything else. That goes against how we do public health. Another thing is we have to look at it long term and not just short term. People were obsessed with the mortality for a particular month, comparing countries and so on. But what's important is not the count for a particular month, it's sort of long-term overall mortality during the whole pandemic until it's over. Another thing is public health is about everybody in society. And with these lockdowns, we have protected the Zoom class who can work from home. People like you, journalists, people like me, scientists, but also bankers, attorneys, and so on. While those who prepare food, people in supermarkets, in meat factories, people who actually have electricity, and so on, they have had to work. So the burden has been put on the middle class and the working class. And of course, the burden has also put on children who needs education. That has long-term consequences if you don't give children the proper education, and schools are very, very important. And for rich people, they can put their kids in a private school, or they can hire a tutor, or they can afford to have one parent at home to homeschool them. That's not possible among those less affluent. So the working class children has been especially hard hit by this response to the pandemic.
You're saying that I don't even know what age group it is, but you said that the effect of COVID, or the risk of COVID for this young age group is less than that of annual influenza. I mean, that's, I don't think, something that's generally known.
Yeah, so I think by now it's about 350 or so reported deaths of COVID in the US for children. And we don't even know how many of those are truly COVID, because nobody has bothered to go through all those electronic health records, which I think CDC should do, as Martin McCary, who is a professor at Johns Hopkins, has been urging. But that hasn't been done. So we don't know exactly how many, but it's at most 350. If we look at annual influenza, depending on, and that's for over 1.5, basically 2 seasons, 1.5 years. If we look at annual influenza, depending on the severity of the particular strain that particular year, between 200 and 1,000 children die from annual influenza every year. So, of course, every death is very tragic for whether it's influenza or COVID, and of course, death of children is especially tragic. But we never closed down schools for the annual influenza. And actually, they would be actually more rational for doing that, because influenza is actually spread a lot by children. So the schools and children are one of the drivers of the spread of influenza. But the opposite is true from COVID. Most children who are infected get it from some adult. And the children are not very good at infecting others. So it makes no sense to close schools. And we saw that from other countries who have kept them open. And we should never, ever close the schools, any other schools, for COVID as we go forward. They should be open, and we should let the children be children. And education is very important, and we should let them get that in-person education. And we know that both teachers and students, children, have said that online teaching is certainly not even close to as good as having the personal teaching, both for education but also for their social development and hanging out with their friends.
Well, so, we've been hearing a lot about the Delta variant, a lot of scary, frankly, headlines about the Delta variant. Maybe we're going to need to go back into lockdowns in the US. You've described some of the collateral damage, some of the issues. What do you think about this discussion that's happening now?
Well, for any virus, there are going to be mutations, so there are going to be variants. And some variants will be more successful than other variants in sort of spreading among the population. So therefore, it's not surprising that you have variants and that some variants will take over. So this is not at all surprising. The Delta variant may be somewhat more contagious, but that's not the game changer. What would be a game changer is if you got a variant that started to kill young people, so started to kill children. And the Delta variant is not doing that. What would also be unfortunate is if you have a variant so that the natural immunity that you have from COVID or from vaccine doesn't work with the variant. But we know that if you've had COVID, you have very good immunity, not only for the same variant, but also for other variants, and even for other types of sort of cross immunity to other types of coronaviruses. So we know, for example, that if you had COVID-19, SARS-CoV-2, you also have immunity to SARS-CoV-1, which we had earlier, a few years ago. And it also provides protective immunity to the other 4 common coronaviruses that are endemic, that we've all been exposed to and we will continue to be exposed to. So I don't see any problem with the Delta variants or any other variants that sort of changes anything. It's not a game changer. And the best approach is to make sure that all old people get vaccinated to protect them. And then we should not have lockdowns. We should let people live their normal lives. And if there are an old person who hasn't been vaccinated, they should get it and then wait 2 weeks. And after 2 weeks after vaccinations, they are protected and they can also participate in society. But until they are vaccinated, of course, all people need to be very careful.
So I want to talk about natural immunity in a moment. This is very important because there's been a lot of different messaging, frankly, about that. But before we go there, in places like Florida and Louisiana, for example, right now, there's a surge in cases. Your thoughts?
So it's important to differentiate cases and mortality. So the fact that somebody tests positive is not necessarily a worry, and it's something that we would expect, and it's something that's going to continue to happen because as COVID-19 becomes endemic, people are going to be infected. If you test them, they're going to test positive. And they might even have the virus replicate before the immune system sort of kicks in. And they could even some of them might even spread it. But as long as people are asymptomatic or mildly symptomatic, this is nothing we should worry about. So what we do have to worry about is the mortality and also hospitalizations. The benefit of being immune, whether it's because you had COVID or because you're vaccinated, is not to avoid being infected and test positive. That's going to happen. The key thing is if you have had COVID already or if you are vaccinated, that protects you against severe disease and mortality and death. And we can see that cases and mortality has sort of started to decouple now. So for example, in the UK, there was a wave that peaked in about mid-July of cases. It was a very sharp increase and now it's going sharply down. For mortality, it's just a tiny blip. So this is a contrast to before the vaccines, before focused protection, when cases rose and then mortality also rose, sort of in parallel. But that has sort of been the vaccines and the immunity from people who have had COVID is sort of decoupling that. We can see it in Sweden, which had the first wave and the second wave. There were increasing cases, and there was also an increase in mortality corresponding to that. But then there was a third wave that peaked in April. It was a third wave of cases, but mortality kept just going down. and it now has been close to zero for more than a month. So also there was a decoupling, and that was actually the Delta variant that was the third wave. That was predominantly the Delta variant was increasing proportion of those in the third wave of those cases. So, but it decoupled the cases and death. And we see the same thing here in the US now in the summer wave that we see in the southern state. There has been quite a few increasing cases, but the mortality, there's a blip because not everybody is vaccinated, not everybody has had the disease, so not everybody is immune, so there's a little bit of a blip. But we don't see the same close correspondence between cases and death as we've done in the past. So that's a very positive thing and a very good thing. And it kind of shows that we are on our way from the pandemic phase to the endemic phase. And we will always have COVID-19 with us. It's not going to go away. We can't eradicate a virus like this. So it will always be with us. But when people get it exposed for the second time or third time or fourth time, the immune system helps making sure that it's not a serious illness or leads to death. And of course, new people are born every year and they are susceptible. They haven't had it. So when children are born, they don't have the immunity to this particular virus, but we know that it's very mild for children. So this is a very good thing, that this virus is not harsh on children when they get it the first time. And as long as they get it the first time when they're a child, if they somehow try to stay away from it until they get 80 and haven't been exposed to it, will be impossible. But if you could do that, then of course when they're 80 and susceptible, they would be of high risk. But as long as they're exposed as a child, their immune system will sort of build up, and then the next time they will be protected with their immune system.
You mentioned how the virus will always be with us, so to speak, and I'm very curious about that because it appears, at least in some of the public messaging, that we're attempting to eradicate the virus entirely. So let's put a placeholder on that for a sec. But I want to talk about this natural immunity that you mentioned. There's been a lot of, I think, conflicting messaging about natural immunity. You seem to be saying that it's strong and vibrant and useful, yet at the same time, there's this kind of push to vaccinate people, whether or not they have natural immunity. Am I seeing this right? What's going on?
Yeah, so first of all, it's expected that we would have good natural immunity from a virus like this. So it's not a surprise that we do have it. There has been studies showing that we have good immunity from having had COVID before. There are very few people can be reinfected and test positive, but there's very few cases where somebody had it and then they get a serious disease afterwards. And there are millions of people who had COVID. So if this was a common thing, we have been shown up all over the place, but it hasn't. So it's very rare. So once you've had it, you have good protection from your immune system for serious disease or for mortality. There has been some direct comparison. There was some data from Israel that came out recently showing that if you have a vaccine, you are 6.7 times more likely to be reinfected than if you have had COVID disease itself. So we would expect that you get better immunity from the disease than you do from the vaccine. And of course, that's only one study, so we don't know exactly, but we can confidently say that having had the disease gives you at least as good and probably better immunity than from the vaccine. We obviously also know that empirically, we know that if you've had the disease, you have at least 1.5 years of good immunity because the virus has been with us for that amount of time. So we know that there's long-lasting immunity from having had COVID disease. From the vaccine, we have less information because it only came in December, so it's a little bit over half a year. So we know that there's good immunity for 6 months, and hopefully it's longer, but we don't have the same amount of data, the same evidence as we do for natural immunity, from having the disease naturally. But as a public health scientists, it's very surprising that this is not recognized. So we are forcing people who've had the disease, who have good immunity, to take a vaccine, even though they already have immunity, that's better than, or at least as good or better than those who have only had the vaccine. At the same time, there are a lot of people who need these vaccines who are not getting it. People in India, in Nigeria, in Brazil, where a lot of older and especially poor people do not get the vaccine because they don't have enough doses. So those are the ones we should emphasize to vaccinate, and we should view this as the global thing of vaccinating the old everywhere in the world, instead of vaccinating people who already have very good immunity against the disease.
You mentioned that people are being forced to take a vaccine. So I don't know, at least in the US, of anyone actually being forced to take it directly. But tell me what you mean when you say that.
So there's a push both for vaccine passports and vaccine mandates. So if people want to have a job, stay at the job, they are required to take the vaccine or they'll be fired. Or if they want to study at the university, many universities are requiring vaccines from all the students. So there is these vaccine mandates and vaccine passport. Or I think in New York City, for example, now they're requiring, restaurants are forced to require vaccinations for people to go to the restaurants. So that's a sort of a very coercive way to get people to vaccinate. And I think that's very bad for public health. One reason is that why do you coerce people who are immune or people who are young who have very small risk when the vaccines are much more needed for older people in other places? So that's an ethical aspect to it. I think it's very unethical to do so. The other aspect is that if you force something on people, if you coerce somebody to do something, that can backfire. So in public health has to be based on trust. And if public health official wants the public to trust them, public health officials also have to trust the public. And I've been working on vaccines for almost 2 decades now. And one thing that we've always sort of tried to do is to maintain good confidence in vaccines. For example, measles vaccines are very important, polio vaccines and so on. And there is a small group of people who are very vocal, who don't like vaccines, but they haven't really been able to put any dent in the confidence in vaccines. It's very high in the US. So I think we've been very successful to sort of maintain that confidence. But right now, with these vaccine mandates and vaccine passports, that coercive things is turning a lot of people away against vaccines, not trusting them, for very understandable reasons. Because why do you have to force somebody to take the vaccine if it's so beneficial to you? That's sort of one rationale. So those who are pushing these vaccine mandates and vaccine passports, sort of vaccine fanatics, I would call them, to me, they have done much more damage during this 1 year than the anti-vaxxers has done in 2 decades. And I would even say that these vaccine fanatics, they are the biggest anti-vaxxers that we have right now. They're doing so much more damage to vaccine confidence than anybody else. And even if they manage to sort of coerce somebody to take the COVID vaccines, because people feel, okay, I have to take it because I need to go to university, or I have to because I want that job, or I want to go to restaurants, and so on. So even if it manages to get those people to take the COVID vaccine, it will turn them off from public health. It will make them distrust public health and turn them off from other vaccines that are not mandatory. So it has sort of ripple effects on other aspects of public health that are very unfortunate. And I'm a native of Sweden, so I know a little bit about Sweden. And Sweden has one of the highest vaccination rates in the world and highest confidence in vaccines in the world. But there's absolutely no mandates. It just doesn't do it that way. It's completely voluntary. And I think if you want to have high confidence in vaccines, it has to be voluntary. There shouldn't be any mandates.
Well, and let's talk about this. You said, there's 1,000 times difference between the risk among a young person to an old person. I mean, just broadly speaking. But so where is the kind of cutoff, right? There's a high risk area where I guess you would suggest most people should be vaccinated, and there's a very low risk area. So just to tell me how that works.
So the way I reason about this is that whenever there's a new vaccine on the market, or a new drug for that matter, we know that it works, we know there's efficacy, and we know about common adverse reactions. For some vaccines, you might have some sore arm, or some rash, or fever, for example. But we don't yet know about rare but serious adverse reactions when the vaccine or the drug is approved. It takes a couple of years to do that. So now if we look at somebody who is, let's say, 76 years old, if they get infected by COVID, they have quite, it's not extremely high, but they could very well die from the disease. So from COVID. So if there then is a small risk from the vaccine, it's a no-brainer. The protection from COVID is much more important than even if there is a small risk from the vaccine. So people in their 60s, 70s, 80s and so on, they should, in my mind, definitely take the vaccine, because the benefits are large, and there might be some small risk, but if there is, it's very small. On the other hand, if we then go to the other side of the age spectrum, the children, we know that at risk of mortality from this is minuscule. They can get it, but many will be asymptomatic, or they will be only mildly symptomatic. But the risk for more serious consequences is very, very small. So then, even if there are small risk of a serious adverse reaction from the vaccines, then we don't know what the balance is. And we know now that, we didn't know that when the vaccine came, but we learn more and more about the adverse reactions. So we know now that in young people, including children, the Pfizer Moderna vaccines can cause myocarditis, which is an inflammation of the heart. That's something we would like to avoid. So it's not at all clear for children what is the balance of the pros and the cons of these vaccines. So, and there could, of course, be other adverse reactions that we don't know yet about. So to vaccinate children, I think at this point doesn't make sense. Now, you asked about the cutoffs, and I don't know where that is, because it's sort of a gradual thing. So it's sort of clear cut on these two ends, but in the middle is less clear. I guess I can't say that, what that is, but then I think we have to be honest about those things. Now, if you are, let's say you're 25, you have very low risk for mortality from COVID. On the other hand, if you work in a hospital or as a nursing home staff, then I think you should certainly have the vaccine, because not necessarily for your own protection, but to protect the older people that you're working with in the nursing home or in the hospital.
Well, okay, so what about this case then? You know, this is probably a case many people are asking themselves about today. You know, you have a older relative, for example, grandmother, right? Grandma's been vaccinated with one of the vaccines, and you have a small child or 25-year-old, 30-year-old that wants to visit with grandma. For that reason, should they be vaccinated? How do we think about this?
Grandma should be vaccinated. That's the important thing. That's what's going to protect her, whoever then she meets. Mm-hmm. And I'm sure grandma wants to see her grandchildren, and she should do that, and she should enjoy them. And when it comes to COVID, the children are not very good transmitter of disease. Now, if you are old and you're frail, your immune system goes down. And a lot of old people die from some common virus that most of us are able to handle, because we still have a good immune system. Who knows who that older grandma will get that virus from? It doesn't have to be COVID, it could be something else. It could be the flu, but it could be one of the other coronaviruses or any other virus. They will catch it from somebody, somewhere, but we shouldn't sort of start blaming our children, for example, if it was a child who happened to be the carrier, or if it was somebody in the supermarket, or maybe the neighbor. It could be anybody of those things. But we have never started to blame these people for killing grandma, and we should never do that.
Well, and there's also this element, I mean, basically you're saying here that and I want to reiterate this because, again, I don't think this is commonly known. We keep seeing these headlines that this and this politician, despite being vaccinated, has tested positive for COVID, right? Apparently that's a normal thing. Like grandma or whoever could get it from someone that's vaccinated, someone that's not vaccinated, or could be exposed to it at least. And it's not clear that how much the vaccination would help with that.
Yeah, so the immune system works to prevent serious disease and death, but it doesn't prevent you from being exposed or from having the virus enter the body, because the immune system can't go into action until the virus is in the body. And depending on how long it was since you had COVID or since you had the vaccine, the time it takes to sort of beat off the virus when it comes might vary. If you have had it very recently, you still have all these antibodies, and it might be very quickly taken care of. But if it has been some time ago, the virus might still start reproducing in your body, in your cells, before the immune system sort of kicks in and takes care of it. But that somebody who had COVID or have had the vaccine test positive for COVID, that's not what you would expect happen. So that there should be no headlines about that. If we did that with all the viruses that we deal with, there are dozens of them, and if we tested for all of them, and if there was a headline as soon as a politician tested positive for one of them, with scary newspaper articles, then we'd all be hiding under our beds all the time. We can't do that. This is part of society and the part of things that we deal with these viruses, and we have an immune system that is a beautiful thing. It's a fantastic, biologically it's a fantastic thing how it operates, and we have lived with that for hundreds and thousands of years, and we should continue to do that. What's new with this COVID-19 is that it was a new virus, so everybody's susceptible. Nobody has immunity towards this. I think there's some people have cross immunity from other coronaviruses, but when so many people are susceptible, then you get these waves and this pandemic. And I think it was clear as soon as I heard about it started in Wuhan in China, but then there was an outbreaks in Italy, northern Italy, as well as in Iran. And as soon as I heard about those outbreaks in northern Italy and Iran, it was clear to me that this was going to be a worldwide pandemic, because it sort of came there, nobody knew how it arrived there, we don't know who brought it there. So it was clearly that this was very contagious and that it will eventually reach all parts of the world. And that's exactly what happened.
So there seems to be a focus on this concept of breakthrough infections, and as if that would be some kind of significant problem with respect to the efficacy of the vaccine. So this is some kind of misconception?
Yeah, I think it is. So I don't think we should be so preoccupied with that. The key thing is that both natural immunity from having had COVID as well as the vaccines, the key thing is they protect you from having severe disease and from death, and that's what is the most important. We expect that even if you have immune, you can still be exposed and you can still get the virus in your body, because the immune system doesn't go into action until the virus is in there. And depending on how long it was since you had the vaccine or how you had COVID, your immune system might react very quickly, or the virus might actually start to replicate in the cells, so it'll take a little bit longer. But your immune system is still there, taking care of it and protecting you from a bad outcome.
Well, so tell me about this, it will always be with us. Because, again, even for me, there's a lot of confusion about policy and what it's actually trying to accomplish. Are you seeing the policies trying to eradicate this virus entirely? Is that even possible? I think you said earlier that it's not. Or what should be the goal if that's not correct?
So, for example, Australia has had a goal of eradication. And you can see it in two ways. You can see it that no, they haven't succeeded because they still have it, or you can say that they've been very successful because they've done it 6 times. Every time they do lockdown, they eradicate it, and then they repeat eradicating many times. So no, it's not possible to eradicate it. It will be with us. And the key thing is, once we all have immunity from having had the disease or from the vaccines, then usually if you had the vaccines, you're going to be exposed to it the second time, and then you will hopefully improve your immune response even more. That's going to happen, and it will be like the other four coronaviruses that we're already dealing with and that we have dealt with a long time. The only two diseases that has been eradicated are smallpox, which took enormous effort, but it was also a much better candidate for it. The other disease we have eradicated is rinderpest, which is a disease in cattle. But those are the only two diseases that has been eradicated. We have for a long time tried to eradicate polio, and I think it is possible to eradicate polio, and we should continue those efforts during this time.
So what about the countries or states that are in these successive stages of lockdowns? Is this kind of a lockdown forever model? I mean, what can they expect if, as you said, this virus will be in those societies forever? And frankly, it seems there's this huge, as you mentioned, collateral cost to doing them.
So the question we have to ask Canada and Australia is, the question is, what's the end game? Because you can't keep locking down forever. Australia had an advantage because it's a seasonal disease. The smart thing that Australia did was to position themselves in the southern hemisphere, because the COVID came when it was the winter in the northern hemisphere, when it spreads very easily. So in the northern hemisphere was impossible to sort of suppress it. Because Australia got it in the summer, they were able to suppress it their first summer, the winter for us, and then they closed the borders with hard quarantines. So they had the advantage of being able to do that, and therefore they could suppress it quite successfully. On the other hand, they weren't able to keep it out. It comes getting back, and they have to keep doing the lockdowns. So without a vaccine, they would then have to do that forever, which doesn't make any sense. We were very lucky. That has been the huge success, I think, of this during this pandemic, because there's been so many fiascos. But the vaccine has been a huge success to quickly get a vaccine. So what Australia must do now is to say, okay, everybody should be vaccinated. All the older people should be vaccinated, and then remove the lockdown and open up. So protect those older people who are at high risk through vaccines, and if they don't want to get vaccines, they have to protect themselves through physical distancing. But they should get the vaccine, I think, all of them, and then open up. And it will be endemic in Australia, just like in every other country. But obviously, because they have suppressed it so much, they don't have the same levels of immunity as we have, for example, in the US or in the UK or in Europe.
Okay, so that's pretty fascinating. Basically, you're saying that by doing the lockdowns, you're kind of just delaying the inevitable process. Do I understand that correctly?
Yeah. And there's, of course, a lot of damage during this process. So you could argue and say that, well, you do this severe suppression until you get the vaccines. With that logic, they should now open up. But then the question is, how long is it worth waiting for the vaccine? And the damage from the collateral damage from the lockdowns are quite severe. And it has been, I think, severe both in Australia and I think even more so in Canada. If you waited a month or two for a vaccine, maybe it's worth doing those lockdowns for 2 months until you get the vaccine. But to wait a whole year, no. There's too much damage, too much collateral damage from the lockdowns on public health, as well, of course, as education and other aspects of society. But it's too much damage so that it's not worth it, and it would have been better just to do focused protection or protecting those who were vulnerable and do a good job at that, which we didn't do.
Just again, jumping into these collateral damages, you mentioned the mental health cost. I remember reading this statistic, which I cited a number of times in interviews, something like, in this one study, 25% of teenagers had suicidal ideation. I mean, 1 in 4. I didn't even know what to think about that. But just can you expand a little bit on this mental health collateral costs?
Yeah, that's very tragic. I mean, I think the normal number was like 4 or 5%, and now it was 25. So that's, I think, very tragic. And we have had a lot of mental health consequences. There's also been opioid overdoses that has increased. And of course, also a lot of that is not very measurable because a lot of it is hidden. So, and I think that's something that we as a society have to really try hard to repair the damage and overcome that. So, and not just psychiatrists and psychologists and counselors, but I think it's sort of we have to take on that role, all of us, with our neighbors, with relatives, with people at work. With I think the church and other religious organizations has an important role to play to help this. So I think that's something that we collectively, as a society, have to try to repair all that mental health damage that we have seen during this pandemic. And I have 3 children. My oldest is 18, and I was never worried about him in terms of COVID, because he's young and if affected, he will do well. But I was very concerned about his mental health. So I was urging him through the whole pandemic, go out, play basketball with your friends, go hang out with them, do those things, do your social activities. Because that was my concern. I wanted him to have a normal life as much as possible.
So one of the things that a number of people I've spoken with, even on this show, have mentioned is that the required agencies, the CDC, FDA, that some of the data that should be collected to get the full picture of the reality of the disease and the vaccines and so on just simply isn't being collected. I wanted to see what you think about this.
I think that's true, unfortunately. And there are a few key things that should be collected, and that sort of, I think, is the role of CDC to do that. One is to take a regular surveys of the prevalence of immunity, of antibodies, as well as T-cell immunity, so that we know what is the level of immunity in the population in different states, but like random surveys, but across the country and over time. Spain did in the spring of 2020, they did a random survey of 60,000 people, different ages and different locations. So it has been done in some places, and my colleague Jay Bhattacharya did an early survey in Santa Clara County. But those are things that CDC should do, and they should do it across the country and regular interval over times. So that's one thing. Another thing that we failed to collect data on is about those who actually do, who are reportedly the reported COVID deaths, because many of them are truly due to COVID, but some are not. Some died with COVID, and we don't have a good idea of how many belongs to each group. So it might be the primary cause, it could be a contributing cause, or it could be completely unrelated. So there again, we can't do everybody, but we could do a random survey from different places and different age groups to see how many of those who are reported to have died from COVID actually died from COVID rather than with COVID. For children, there's about 350 children who have reportedly died from COVID, and there we should, I think, examine everybody, as has been proposed by Martin McCarry from Johns Hopkins University. It's something that CDC could easily do. They have the resources, they have the personnel to do that, and go through the health records and see how many of those who actually died from COVID versus from something else but with COVID. So this kind of basic information you need during a pandemic to help decide what strategy to use, and that hasn't been those data hasn't been collected the way it should have.
And what about on the vaccine safety sides of things? This is actually, a big area that you've been involved in for a long time.
So the best system we have for evaluating vaccine safety is the Vaccine Safety Data Link, which is run by the CDC. It's an excellent program. I've been involved in it for almost 2 decades, developing many of the methods that are being used. So there you use electronic health records to see exactly who got vaccinated and who didn't, and then know exactly what happened to them afterwards. So did they have a stroke or a seizure or heart attack or whatever so many days after the vaccine, and then you can compare that with what would be expected by chance, because you also know what is the rate sort of in the background population of those who didn't get vaccines. So that's a very good system, and it's being used very well, I think, for COVID. The only problem is that it has about 10 million, covers 10 million people, so about 3% of the US population. So in that sense, the sample size is such that it takes time to get the information. The VAERS system, which is the more well-known system, is less reliable because those are spontaneous reports. Anybody can sort of report in, so there's under-reporting. But it also doesn't have any good denominators. Like it's hard to come up with what the expected numbers should be. I think there's been a lot of misconceptions and misunderstanding about this system because each reports are publicly available. So you see, okay, there were so and so many heart attacks or so and so many deaths after the vaccine, but they obviously are going to be just by chance a number. So CDC reports those raw numbers of how many they were, and that's sometimes misunderstood to mean that all of those were actually caused by the vaccine, which is not correct. So what CDC is not doing, which I think CDC should do, is to get some kind of a denominator. And it's not so easy to do, but it can be done, to put it in the context of if this is actually something unusual that we have to be worried about, or if it's just that, well, by chance, if you give 1 million people a vaccine, some of those are just going to die the next month just because it had nothing to do with the vaccine. It's just that a certain number of people die every month. Mm-hmm. So there's been a lot of misunderstandings about it, and I think when CDC doesn't sort of give the some kind of a background rates, it invites people to misunderstand it and draw wrong conclusions from the data.
There does seem to be, though, a spike in reporting in the VAERS system. I mean, I was looking at a graph that kind of shows, that basically kind of like a baseline of reporting, and then COVID vaccines come, and there's a big spike in reporting. What does that mean?
So I'm not surprised by that. Whether the spike is bigger than you would expect, I don't know, but I'm not surprised that it's increasing, and that you get more reports from COVID vaccines than from the average vaccine, because most vaccines are given to children, and not very much tend to happen to children. They're usually healthy, and if they have an ear infection or something, that's usually not reported. So, but when you give vaccines to people in the 80s, a lot of health events happen to people in the 80s. So you would expect that there's a lot more, just by chance, that there are a lot more events when older people get a vaccine than when younger people get a vaccine. So in that sense, I'm not surprised that there is a spike. Obviously also there's a lot of, this is a new vaccine, so a lot of attention to it, so that can also increase the reporting. So with the VAERS, there's a lot of biases in terms of who reports, many people report, what do they report, that just has to do with the sort of the reporting nature of the system. So and that's why the Vaccine Safety Data Link is much better, because it's not based on people reporting something, it's based on their normal behavior of going to the hospital, to the doctor for whatever they have. So there's sort of less bias there, because if you have a heart attack, you go to the hospital whether or not you had the vaccine or not, and it's recorded whether or not you had the vaccine. So there's all these reporting biases that makes VAERS a difficult system to use. It's still very important for things like happen as soon after the vaccine. For example, we know that the COVID vaccines can cause anaphylaxis, usually within 30 minutes after the vaccine, and we know that from the VAERS system. And as long as people hang around and they can get the proper treatment, it's not life-threatening. But so for those things it's useful, but for many other things, the VAERS system is not very useful, especially the way that the data is presented at this moment. It could be done much better.
You're one of the authors of the Great Barrington Declaration, of course, and that's when you outline this idea of focused protection with Dr. Jay Bhattacharya and Dr. Sunetra Gupta. There's a significant backlash to, basically getting this information out and getting it prominent. And so, tell me a little bit about, what you've experienced.
So first of all, there was nothing really novel in that Great Barrington Declaration because it basically said the same thing as the various pandemic preparedness plans that different countries had prepared before COVID. So there was nothing new or novel. There was nothing there that we hadn't said before or that other people hadn't said in similar words. What was very frustrating was that in the media there was this perception that there was a scientific consensus in favor of lockdowns, while among me and my colleagues who I talk with, other infectious disease epidemiologists, the majority thought that lockdowns were not the right approach and that focused protection would be more important. But when anybody spoke up, they would be sort of ignored or silenced or, oh, that's just one crazy person. So what we did with the Great Barrington Declaration was, since there were 3 of us who stated together, we all have been working with infectious disease epidemiology for a long time, so they couldn't dismiss us for not being in the right field of science. And coming from Oxford, Stanford, and Harvard, they're all reasonably respectable universities, so they couldn't dismiss us because of that. So that was sort of the goal, to take what a lot of people already thought and make it impossible to ignore. And I think that succeeded. There was a huge backlash from the media, from some politicians, and from also a few fellow scientists, even though, but there was also enormous support. So we had, very quickly, we got over 10,000 signatures, co-signers, who were scientists, public health scientists, and epidemiologists and so on, at the same time as we by now have 850,000 plus signatures from the public as well, in total, everybody. So there was a lot of support from the scientific community and from the medical community for the Great Barrington Declaration, but it was vilified in the media. And at the time, in October of 2020, our philosophy was, okay, the key thing here is to make it clear that there's no scientific consensus for lockdowns. And then they can say whatever nasty things they want about us. But to get that message out, that there's no scientific consensus for lockdowns, I think was the most important first step. And I think that succeeded. So in that sense, we're very pleased with the outcome. There were personal attacks, but I guess we sort of expected that maybe. I'm surprised that it was mischaracterized and vilified for things sort of that it wasn't, instead of taking a serious discussing of how do we better protect the older people. We had some very concrete proposals, which obviously had to be adapted in different countries, but some very concrete proposals for people in nursing homes, for people living alone at home, etc. That discussion never happened, unfortunately, and that's tragic, because I think that would have saved many lives during the second wave that we knew were coming. And that's why we wrote the declaration in October, because we knew there were going to come another wave now in the winter in the Northern Hemisphere. But there was censoring by Twitter and by Facebook and by Google-owned YouTube and so on. So as a simple public health scientist, it's sort of a little bit of a shocking to suddenly be in such a situation. I thought I would be a simple scientist for the rest of my career, and then I'll retire and so on. But so it's a very strange situation to be in. But that's what happened.
Why do you think they were so determined to censor you and these other scientists?
Because they don't have any good public health arguments. So they couldn't respond with public health arguments saying that we should do it because of this or that. Because the lockdowns goes against the principle of public health, while the focused protection that we proposed is very much aligned with traditional public health thinking. So they didn't really have any good scientific or public health arguments. So if you don't have that and you still want to push back, you have to use, and you can't ignore anymore, you can't silence anymore, then you have to use either slander or you have to use censoring.
But why not just consider what you were proposing? I mean, that's
a good question. I don't know, because there's no public health reasons for it. So that's politics. And I don't understand what the politics behind that was. There must be something. But probably as a journalist, you probably understand politics better than I do as just a scientist. So there's no public health reasons for it. There's no epidemiological reasons for it. No scientific reasons for it. But there's obviously some political issues going on there which I don't really understand, and that other people would have to try to figure out and maybe explain. But that's sort of outside my area of expertise. So yeah. I'm just stunned. I'm just very surprised.
But the cost of it, you're basically saying, is, some countless number of lives, basically, right?
Yeah. So these, the collateral damage is enormous, and it's long term. So we're gonna have that with us for a long time, unfortunately.
There's a kind of a curious element here, which is just that the implementation of these vaccines effectively does a sort of focused protection, doesn't it?
Yes.
I mean, I think that's very interesting how things played out.
Yeah, so when the vaccine came, that was the best tool available for focused protection or protecting the old. There were other things we could do before that. But of course, when the vaccine came, that was an ideal tool for protecting the old, high-risk people. So that was a very good thing, it was a great thing. And I think the vaccines have saved many lives.
Well, I guess what I'm saying is that it seems like, in some way, the Great Barrington Declaration was actually implemented, despite being maligned, right?
I think it was in many places it was implemented in terms of the vaccines. In terms of other way to protect the old, there were some places that implemented it, like, say, for example, Florida did certain things.
Directly in that case, right?
Yeah. But yeah, with the vaccines, most places did put some emphasis on the older people. But it's a little bit variation. So, for example, Sweden and Florida put a lot of emphasis on getting the older. So they were very strict about who could get the vaccines in a strict order. In Sweden, there was even some people who lost their jobs because they sort of sneaked in and took a vaccine when they wasn't supposed to because they hadn't reached that age group yet. But then there were other where they have been much more lax. For example, in India, a lot of young people got vaccinated before all the old people were vaccinated. So it varied a little bit over in different places. But in many places they did, thankfully, focus the vaccination efforts on the old people as well as the caretakers of the old people.
You said something earlier that I want to kind of build a little bit on here, and I pulled something from one of your writings. So here's what you wrote. Ultimately, lockdowns protected young, low-risk professionals working from home, journalists, lawyers, scientists, and bankers, on the backs of children, the working class, and the poor. In the US, the lockdowns are the biggest assault on workers since segregation and the Vietnam War. Except for war, there are few government actions during my life that have imposed more suffering and injustice on such a large scale.
It's very sad and tragic, I think. And I think there's a fair amount of hypocrisy going around. One example is there was one tweet, this was about a year ago, saying that this was from a fellow academic who said, well, here's one thing that everybody can do. When you take an Uber, roll down your window. Well, everybody do not take an Uber. And taxi drivers are among the most exposed to the virus in terms of different occupations. So here we have a person, a very pro-lockdown public health scientist who still wanted to have that convenience of taking an Uber, and not realizing that they're sort of privileged and can take that, while the person driving those Ubers don't have a choice. They have to feed their family. And the scientists have the privilege of taking an Uber or a cab, while children are not allowed to go to school. So it's sort of a disconnect, I think, among those. I would say they're in a minority among the scientists who are favoring or arguing for lockdowns. But there's sort of a disconnect there between the life they lived with being able to work comfortably from home. And I've been able to work very comfortably from home, and most journalists have as well, with their experience and the experience of the majority of people. Another example is, I think, New York Times had a story about, so here what you can do, you should order your food online. Well, that was a recommendation to the Zoom class who can order online. It wasn't a recommendation to the people actually delivering that food or the people who is cooking the food in the kitchen of the restaurants. And of course they are about. So there's been a really huge disconnect, I think, between the scientists and journalists and politicians on one end, and the majority of the population who have sort of lived a very different life, where they have lost jobs or small businesses has gone under, while the big businesses have flourished. And I think that it has sort of been driven by fear, this whole thing. And I don't know what the rationale is, but it has been driven by fear. When I was in my 20s, I worked for a human rights organization in Guatemala. And the way that the military dictatorship kept control over the population was through fear. They made sure that not only the leaders of the opposition were sort of hit, but also regular people, so that there will be sort of a fear within the whole population. I think with COVID, there's also been this driving fear about COVID. And for example, older people, yes, they should be very cautious and take precautions because they are at high risk. But a lot of young people have gone around being very fearful of this virus, even though it poses much less risk to them than many other things that they do in their daily life. Driving a car has a risk with it, and so on. So it's a very strange time we have entered into. And it's a strange from a personal perspective, but it's also strange, like as a father and with neighbors and so on. But it's also very strange from a scientific, as being a scientist, with this very illogical situation where basic principles of public health is sort of thrown out the window, while the working class is thrown under the bus. And one of the principles of public health is that it's about everybody in society. Public health should take care of everybody, not just a small group of people.
So, in this vein, another thing that you said a little bit earlier was, you said, I think, that it's unethical to you to basically encourage or force younger people to get the vaccine when there's all sorts of older people around the world who don't have access to it, like that those vaccines could be better used for the people that need the focused protection, so to speak. Tell me a little bit more about this.
Yes, I think it is a problem. I think it is unethical. So we are giving now the vaccine to people in the US or in the Europe, Western Europe, to people who have had COVID already. So they are immune. They don't really need the vaccine. We're giving it to students who are forced to take it to go to university classes, even though their risk from COVID is very, very small. At the same time, there are many older people, many old poor people in India, in Africa, in Brazil, South America, who do not have access to the vaccine and who are dying because they don't have the vaccine. So while we have been successful when it comes to the vaccine rollout to prioritize the old people within the US and within most countries in Europe, we have failed with focused protection when it comes to the vaccine on the global scale. And I don't understand how a university can require a young student who have already had COVID maybe, so they have natural immunity, but require them to take the vaccine. And even if they haven't had COVID, they are very small risk, but they are forced to take the vaccine if they want to go to the university, while there are older people around the world who have not had the chance to get this vaccine yet. It's unscientific because it's basically denying the existing of natural immunity from having had COVID disease. And it's unethical because it's leading to more death in other countries. So I think the universities should all change their policy of not having any of these vaccine mandates if they want to live up to the age of enlightenment, where we actually believe in science, including natural immunity, as well as we behave in an ethical manner. Well, it's very surprising that universities will take these requirements, make these requirements.
Well, and presumably they're, as you're saying, these vaccines have been, effective at protecting the old, it would provide some sort of opportunity for, we call it vaccine diplomacy. That's usually described as in a more pejorative sense in terms of, for example, what China has been doing. But in this case, imagine it would be seen very positively by people, by these countries that need it.
Yes, yeah, and it would be the right thing to do.
So we've gotten all this conflicting information from public health authorities. And in some cases, as you say, the guidance didn't seem to have much to do with public health policy. There's this general distrust that I've been hearing all over the place. There's a general feeling that there isn't a trust in these agencies which are responsible for these things, from the WHO all the way down. And you say trust is so critical. So what happens now?
So it's not a surprise that the trust has plummeted for public health agencies and public health officials because of these mixed messages, and also things like not taking natural immunity from having had COVID disease into account and still forcing people to vaccinate. So it's very understandable that the trust has gone down. And I think both within the scientific community and the public health community, we have a lot of work to do to regain that trust. And I think it's going to take a long time. But it is important to do that and to try to regain that trust. And I think the only way to do it is to be very honest and straight with people. 2, to trust the public. 3, to actually listen to the public and not just make public health policy based on the Zoom class, which is scientists and journalists and the neighbors, whatever they are, but to really listen to everybody in society, and especially those who are less affluent workers, but of course also children and old people. So I think that's a third failure during this pandemic, that public health officials do not have a tendency to dismiss people when they have concerns, for example, rather than listening to them. And when it comes to vaccines, for example, I think vaccines is one of the greatest inventions of mankind. It has saved countless lives. But when people are concerned about the safety, that's a serious thing. And I'm obviously very concerned about it because a lot of what I do in science is to study the safety of vaccines. So one has to take people's concerns seriously and then be honest with it. So as public health scientists, we have a lot of work to do for many years to come to regain that trust, because I think that the loss in trust is very understandable.
Well, Dr. Martin Kulldorff, it's such a pleasure to have you on.
It's been a delight talking to you. Thank you so much.